also presented at ASCO was this real world data looking at retrospective data for patients in first line setting who had gotten luspatercept versus EPO and looking at the outcomes. Wanted to get your comments on the results of that and if that adds to what you're thinking about how these patients should be managed in the first line setting.
I, I personally, I don't know if my colleagues, I like real world studies. I know there's always phase three trials, but I think real world studies, they're the actual patients we see in our practice, right? So I feel that it helps affirm the things I do in the clinic on a daily basis. And one thing about that abstract that was presented, one thing that really caught my eye was the number of RS negative patients,
Yeah.
right? Because all our phase three low-risk MDS patients, the majority are ring sideroblast positive. But in our practice, majority of low-risk MDS patients are actually RS negative, right? And the results with the improvement in the hemoglobin, number of patients who were able to have red blood cell transfusion independence for like 12 weeks or longer, it definitely favored luspatercept compared to ESAs. Yes, it's not a phase three trial, but the number of RS negative patients included, that helped affirm what I do in my practice, where I offer it for both RS positive and RS negative patients in the frontline setting.
I agree. I think real world data is always helpful. We see it oftentimes, maybe some inconsistencies in the clinical trials and real world data. To me, not shocking to see, in the real world data, because in my real world experience, it is very much beneficial for RS positive, RS negative, and really for all subgroups of low risk MDS. Hence why to me this kind of confirmed what we see clinically.
Yeah, these are really important points. I totally agree. And, thinking about what we've seen in other aspects of cancer care, it's not uncommon for the real world results to be much less favorable than what happens in a trial. And sometimes it's because the populations are different and you're cherry picking off, younger, healthier people without comorbidities with maybe less aggressive disease. Because if you progress and get too sick, well, you don't get on the trial. You can't go through the rigmarole to enroll. So there's great reason to think maybe we wouldn't find similar results in the real world. And if anything, when I look at these real world results, they look as good or better than commands on most of the outcomes, and I'm a little bit surprised about that. I didn't think they would necessarily look meaningfully worse, but I definitely didn't think they'd look better. So it's reassuring that, like you said, in the real world setting where many more of our patients are actually RS negative and thus have worse prognosis, that this therapy appears to perform as well as it did in commands, if not better. And, again, it's really probably just the new standard of care then.
So I think taking both of these together, is it fair to say that really we can move beyond serum EPO levels, the ring sideroblasts? I mean, would you even consider this at all anymore in making your decision?
It's going to be hard to get us to stop doing those things.
Yeah. I'll still bet.
Okay, all right, fair enough. What about this increased use of luspatercept in the first line setting? I mean, what do you think this is going to mean for sequencing, cost, future therapies?
Well, I think, for patients, I was mentioned earlier by my colleague that every 3 weeks compared to weekly, right? That's less visits, less co-pays, right? But also like reducing transfusions, that's less hospitalizations, right? That's also financial toxicity as well, right? And I feel, as my colleague also mentioned, that sequencing, if we pick this as our frontline therapy, what's the best way? As it was mentioned, do we add ESA? I'm excited about that. I'm excited about that as well, the combination. Then what about that new telomerase inhibitor, right? Not so new now, but imetelstat, right? We have data about using it post luspatercept, right? And also there is in the IMerge trial, which they evaluated the drug, they had patients who had baseline EPO levels greater than 500 who never saw ESA therapy, right? So more options are better, but sequencing is a big question. We don't know what's the best way for that.
Yeah, what I wish I had some data about, and there may be some out there that I haven't seen, is what happens after failure of luspatercept. if you try EPO? Do you get responses in 10% of patients? Do you get none in anybody? Is it, 30%? What does that look like? First line ESA responses in terms of transfusion independence are always around 30% in all the different trials. But we don't know what that looks like.
Yeah, and I would say, to piggyback off of that, thinking of it the other way, we do know that, response rates to EPO up front aren't obviously quite as well as we see with luspatercept, but seeing luspatercept used in the second line isn't quite as good as you would see with frontline. And so if thinking of sequencing, I would rather use a drug that I know works better, especially when we're using it up front. And in addition to that, knowing that I only have to administer it every 3 weeks, it's a much easier sell for a lot of my patients. And I think that for sequencing, I agree that we have some other options entering the market here now with low risk MDS, but especially when I look at the duration of response with luspatercept, it's incredible, and so that's why I tend to prefer that across the board.
Yeah, and reflecting on something that Dr. Shameem said a moment ago too, what matters to so many of my patients isn't what's measured on clinical trials and not reported out at the ASCO meeting. And it's like, how many times do they have to drive all the way to the clinic and pay for parking and pay for increasingly expensive gas and the cost of all the other things in their lives, or take time off of work, have somebody else take time away to take them there, and then get pre-meds before transfusion and get zonked out, and then they don't sleep well that night. And I worry about the corollary issues of needing lots of transfusion support in these lower risk MDS patients who on average will live for a long time. So, when we see alloantibodies develop, and then all of a sudden it takes half a day to find a unit of blood for that patient, or you have to have them come back another day, that's a big problem. Iron overload. We still don't really know what we should be doing about that, when to intervene, how to intervene, what are the right targets. But we know that when you develop it, and if you don't do something about it, certainly some patients do get harmed by that. And then for my team, we never have enough clinic rooms. We have even fewer infusion chairs. And if I have to have somebody coming in for blood every week or two, they're taking up a lot of time in a chair of a nurse. Someone's taking vitals. They're in and out of the exam room. Maybe I'm seeing them too, or my nurse practitioner is. And ultimately, with those things being scarce resources, that means there's somebody else who maybe we couldn't get into the clinic as soon, or somebody else who we didn't see that day who maybe needed us, and we had to kind of defer them a day or two. So with resources always being constrained, this is a unique situation where the efficacy of luspatercept lines up with what patients care about and what our practices care about, so that we can serve more people and kind of maximize the benefit that we give to our communities. A lot of things that we do in cancer care aren't like that either. So that's nice.
Yeah, I would say even before commands, I was using that as the logistical benefits as a selling point for a lot of patients. And it was very easy. When patients hear a weekly shot, it scares them. But when they hear it's every 3 weeks, and it's much easier for them to prepare for that and have maybe a little amnesia and forget about the last one. And so it's easy for them to accept that. And so again, weighing in on that quality of life, and also I think of it too as to piggyback after Dr. LeBlanc, the other idea of the reminders, coming in every week to the cancer center, a reminder of your diagnosis, and so we can space that out to every 3 weeks. It really gives them 2.5 full weeks of not even thinking about me or our center.